Well, hello, everyone. Thanks for joining the webinar. I'm Eric Christensen. We've got all of our panelists here today. We're going to give just a minute or two more to let some more attendees trickle in here. You can see that they've been slowly joining. So we'll get kicked off in just about a minute.
Eric, we should have had our hold music on,
No.
when we start. No?
You can sing. Can someone sing?
No. Get up, stand up for your rights.
Yeah, we'll leave that one. We'll leave that one to Bob.
Yeah, Kendall, that must have, is time to change our intro, our hold music, I guess.
I think we're not going to take it.
Twisted Sister.
I should have made that part of the poll. That would have been a good. What's the new hold
Twisted
music?
Sisters going. We're not going to take it.
Yeah, okay. Okay. Eric, once we hit like 65% with our attendance, can you, we'll get that started. I think we had 450 registrants. Is that about right?
Correct. Yeah.
Okay, that's good. Okay. We'd like to know whether those other 250 people are. So something came up.
I'd like a poll as to whether Ryan's, Rochelle's, or Brian's glasses impart a sense of more intellect to them. So of the three choices, who are we going with here? Or Brian McGraw? I forgot. Mine are lost. So obviously there's no intellect involved on my part.
Mine are fully functional. There's nothing about this that my wife likes.
I'd have to sit like back here if I have them off. Does that work?
I think, look, I think it's easy. I think it's Rochelle because they match her jacket. So that's it. Yeah. There's no ifs, ands, or buts.
That pair underwear.
Glasses.
Are they tiltable? They're like they don't split at the nose, but they tilt up. Oh, there you go.
It's like a add-on. It's like a magnet.
That's right.
I've never seen that before. Incredible.
Okay, we know who the smartest of the panel is here.
Way to keep it classy.
I think that was obvious from the start. All right, Brian, I think we're about there.
All right, so I did something wrong. Now I'm not on the screen anymore.
Oh, you're on the screen for us.
Yeah, right. I'm frozen. Okay, good.
I think we're at about that. So you want to
right about 65%. Yeah, we'll do that. So first of all, let me thank everybody for joining. First, I'd like to thank the panelists. Really take time out of their professional day to share their insights, their ideas, things that work in disrupting denials in 2025. So it's a mouthful, this title, right? But the fact is, we're focused on holding payers accountable. That's a strategy that's working. And I think you'll hear that from most of these panelists. However, it's clearly important that if we're going to have to bubble up what we're seeing to the C-suite or to the senior leadership level, we've got to have real actionable data, good comparative analysis, which payers, which denials, which types, and that will enlist us and take us to better appeal outcomes. Eric, you can move to the next slide, please. Thank you.
Just a quick note for everybody. We do want you to be able to ensure that you can hear us and see us. So pay attention to the controls that have popped up with the webinar. Also, I want to invite you all to drop something in the chat if you have a question or in the questions box. We will be answering any questions that do come up during the webinar at the end of the webinar, and then also if we can't get to them, we will send out a full list of questions and answers to everybody. So feel free to drop questions as they come up throughout the webinar right in that questions tab. And then we will certainly let you know what the experts have to say after the webinar.
Sure. Okay. All right. Next one. Thank you. Before the disclaimer, let me just talk to you briefly about Payer Watch. We're an organization that's focused on providing assets and real tools and support to provider organizations across the country, really in this fight against America's health insurance plans. Appeal Masters provides as needed appeal support for organizations, and then we provide what we call tech-enabled denial management capabilities to organizations. So thanks for joining. That's the organizer. I do have to indicate that we do put materials out there, and all these opinions you're going to hear today, these are wonderfully loquacious speakers who are really, really intelligent about what they do. But we don't certify the accuracy or the authority of these materials. It's on them, but they were free to join and very happy to join us. So this disclaimer is really just trying to protect us against anything that we share that you say, oh, we did this and now I got in trouble. Well, we don't think that's going to happen. So next slide, please.
That's it for these.
That's all I need. So with that, I'm going to introduce first Sean Lilly. Sean is the Chief Data Scientist, Chief Data Officer with Hive Healthcare. They have a wonderfully refreshing attitude about providing advocacy to all providers across the nation, and a great story. Sean's going to tell you a little bit about that, and then Sean, I'll start kind of asking the questions, and then when you're done, you can throw it out to the panel and they can answer as they see fit. Okay?
Great, perfect. I've never been called loquacious before, so I'm excited. This is great. But thank you, Brian. Thanks for having us, all these panelists here. It's going to be a fun hour and a half or so. Yeah, so I'm with Hive Healthcare. We are in the data business. And speaking of payer advocacy, we are trying to level the playing field, and there's a number of ways we're doing this. So in the world of payers and providers, payers have all the data, providers have their own data. So we've decided to build a national data set of provider data and to tell that payer experience story across a broad range. So not only can you see what your payer experience is, we're trying to level the playing field, and you can see what your neighbors or your state's payer experience is for that same payer. So that's our goal. So we are drowning in data, and let me just kind of nitpick on how we do that. We use 835 and 837s. We're using the same language that the payers are using, so you can grab that data, tell the same story that they're telling you. We do this every month. We get data every day, so it's timely. We scrub all PHA out, so it's secure. And it's safe, so you can only see your hospital versus the entire state. So think about that for a minute. You have every claim, every remit from every hospital in the nation at some point. We're cooking along here. We got about 600 hospitals now in the tool. And you can kind of, once we aggregate that and get the same payer names and the same specialties and the same inpatient, outpatient, the same, is this a Medicare Advantage? Is this a Medicare commercial, or a commercial versus Medicare fee for service? So think about all those different aggregations. When you put it all together, we can start telling a story of, is what you're seeing in your shop good or bad, or up or down? And how does that relate to the whole state? So
well, there's your first question. There you go. So
yeah,
what would constitute, given the fact you have all this data and the ability to do comparative analysis, what do you call a good denial rate?
So this is kind of our first stab at benchmarking data. Who cares about benchmarking data? Well, if all you see in your own hospital or your own hospital system is a denial rate, and you say, hey, we got our denial rate from 10% down to 8%. Well, is that 8% good or bad? We don't know. So with this type of scorecard, this type of very high level benchmarking, we can say, hey, show that up, Eric, you can start sharing. I just threw some charts up there so you can kind of see, well, if our denial rate is 8%, what's the state's? Is it And not only what the state is what that same payer is for that state. So you can start to actually see if you are higher than what the state is, and vice versa. Maybe you're at the bottom of the stack. So you've got a great denial rate of 4 and the state's at 6. So maybe you start worrying about some other areas of your revenue cycle. So yeah, this is just some simple charts. So the one on the left is 12.3%. That's your denial rate. The state of Virginia in this case is at 7.4%. And these are very broad denial metrics. We try to keep things very simple numerator, simple denominator. So then once you kind of get this view and say, all right, we are high, if you go to the next one, with this aggregation across the state, you can kind of say, okay, well, where are we higher and where are we lower? In this case, the orange is you, the state, and meaning every provider in that state, we've aggregated it the same way. So you can start to doing those apples to apples comparison. So then we split it up by payer type. So Medicare Advantage, I like to pick on them. We call it Medicare Take Advantage. Hope there's no feelings about that. But orange here, 14.8%. Your denial rate is for the state at 7.9%. So you are able to kind of focus down more on your energies in that space and say, hey, either your managed care department or your revenue cycle department, whatever you're looking at is you can start to see where your biggest discrepancies are. So then the commercial versus managed Medicaid versus Medicare fee for service. So that's our kind of our broad payer type. If you go one more, I think I put it out there. The next one's probably, we also did the same thing with payers. So here's like the top 10 payers or something like that. So we can actually go down to the Aetna, the Anthem, the Cigna, the Humana, the Bucas, if you heard that term, United Healthcares, and get to that level and say, hey, United Healthcare, the state, they're denying the state about 4 or 6%, and we're sitting up at 16%. What is the deal there? So as you sit down and think about where to apply your resources, this will help. And then the same thing, we do the same thing with payers. The next slide is, I think, is a specialty. So not only can we tell you United Healthcare is denying you more than the state or the average of the state, we can kind of tell you where. And we just have some broad specialties we put out there. Again, I'm going to say the word broad 1,000 times because in order to get every claim and every remit and get a scorecard for every hospital in the nation, we've got to keep this pretty aggregated, rolled up. We do have all the data on what codes, what procedure codes, what diagnosis codes, but we're going to, for the purpose of this tool, we're going to keep them grouped up in cardiovascular, orthopedics, which is musculoskeletal, OBGYN. So you can kind of go down, and we have a monthly slice as well, but you can kind of come in and say, hey, at the beginning of the year, we were denying, UHC was denying this in this department. At the end of the year, it was better or it was worse. So we can kind of trend that, and you can kind of start to place your peri experience alongside what the state is experiencing as well. It gives you a nice benchmark. Whereas you couldn't do this before.
Let me ask another question here. So you mentioned before diagnosis codes and procedure codes. And so yes. one of the I guess the biggest things we've seen in the last 18 months is the incidence of downcoding, whether it's at the point of payment or even after the fact. Are you able to see how prevalent that are these denials related to downcoding issues?
Yes. So I'm going to talk about, and you're going to hear this as well. So this tool is an advocacy tool. Think of us as a check engine light. And so what we can do along the way is if we have those CARC and WARC codes that have been applied to a downcoding reason, I think we're capturing 3 of them right now. So if that remit comes in with those specific downcoding CARC and WARCs, we just say, hey, this is a remit that had one of those messages on there. Mm-hmm. Then we can kind of flow that downstream and say 1% of your UHC orthopedic remits that came in, or 2% or 1% have that downcoding message on there. You won't be able to see exactly which code, exactly which procedure code, the guts of that remit, but you'll be able to see the percentages. So you can directionally kind of steer your shop into this payer's downcoding us more than before, or downcoding us more than this, or than the state, that kind of thing. I think I have a slide up there, Eric, that spoke to that downcoding. Oh yeah, I guess is this deny rate or downcoding? I think this is downcoding. So you could, as in it, it's another percent. So these are the percent of remits that had a downcoding message. And I threw up here by payer. Again, all these are by payer, by specialty, by payer type. We can go down that rabbit hole on all these metrics. Humana stands out to me. It's like 18% of Humana for this particular.
They have their own financial recovery unit. So I'd like to open it up to the panel for some discussion here about what they've seen. And
Brian, I'm going to be first out of the gate because I had too much coffee this morning, as usual. Sean, in looking at this and considering what you've done here, would it an analogy be to consider this essentially a payer pepper report where Hive has stepped in, assumed the role of CMS? And now instead of CMS reporting on the hospital's behavior, we're going to flip the script through Hive's aggregation of data and provide a pepper report on payer behavior to allow the conversation to go to the other direction?
Correct. Using their data, the payer's language data, the remits, and using it's EHR agnostic, it's timely. I mean, we get this data in every day. So yes, that's exactly right.
Okay.
Sean, I'm glad you brought up the example of downcoding in the CARC and RARC codes. And it seems like you're pulling out certain ones that are designed to identify a reduction in service. One of the things that we've seen, it's especially in the downcoding example, where I think the provider would consider that at least a partial denial, right? Not using those dedicated CARC and RARC codes, but instead using a contractual adjustment code when reducing the level of service or payment. So in some ways, those, I would call it partial denials, reduction in payment are disguised in a sense, that you would have to really go to sort of a next level of payment variances between what you would expect from your contracted rates on what you build and what you ultimately end up receiving, because they're not easy to identify through a dedicated denial code.
Yes, yes. So that happens more downstream than us. So this is like a compass. We're saying, hey, Humana here is speaking that downcoding language more. You might want to look in that direction and go back to your contracts team and go to the contractual adjustments and the expected payment, that kind of stuff. Yes.
Can I follow up on that?
It also prompted another thought, Sean, that I've seen some discussions on LinkedIn and internally with a couple of hospitals recently that in the CARC and RARC codes, it's not necessarily easy to identify what represents a denial versus contractual adjustment versus patient responsibility. There's no real good data dictionary saying this one is a denial, this one is a contractual adjustment. And I'm learning or hearing that different payers classify those in different ways. And I think that has really important implications on plans reporting to State Department of Insurance or reporting to CMS denial data, and then how we as the hospitals and providers are communicating denial data to those agencies and to the plans. How do you all do that? Do you have sort of a reference system on what you consider to be a denial?
We do. That is hard to do because every hospital does it differently and every payer has their own version of the language. So we try to get, again, broad. We try to get the greatest common denominator, and we have a CARC and RARC code roll up, which is always being finessed. And so that's our best shot when we're dealing with a national data set. That's all we have to do is kind of keep those in broad categories, and that's our best way of doing it. Yeah, but to your point, we should keep these payers' feet to the fire and say, hey, we should have a national language. We should get to a standardization of this is the language we should use, and this means this. It's very confusing by design.
Dr. Moore, you were about to make a comment as well.
think Rochelle brings up a great point, because I think, so this is a directional indicator. And I think, one of my golden rules of metrics, especially for physicians, but I think it applies also in any kind of performance metric, is people never question denial metrics or metrics that make them look better than the norm. But yet you could be missing opportunity in a lower that, I mean, if this is what their pattern is across the state and yours is unusually low, you have to ask yourself, are you really good? Or are you putting it in as a contractually, contractual that you made this was a bundling or it was something and it wasn't. And I think that's an area of opportunity that, again, it's directional. If you're really low, you might want to look and say, are we really great? Or are we just categorizing this in a different bucket that makes us look great? Because I have found there's tremendous variance in the way staff will put they'll adjudicate that. For instance, overpayments is an area that things can get to overpayments and come in as an overpayment. It's not really an overpayment. It was an upfront med nec denial that they accidentally paid, and then they're going to pull back and it goes to a completely different team, gets categorized differently. But I just think, the opportunity is kind of more in the relative performance, and then deep dive into, is your relative performance really good, or is it not what you think it means? Is it really bad, or is it not what you think it means? I think, Sean, that's what you're saying, right? Is that it's a direct indicator to look, because if you're somewhere away from the norm of denial activity, you're either really good at avoiding them, or you might be writing them off on the front end and not even seeing it as a claim denial.
Now let's take a minute.
Ryan, I mean, the other thing, the other scenario that comes to mind, especially, and we may get into a discussion with this subsequently, is the 2 midnight rule. You may have a UR process that is shy of enforcing the 2 midnight rule and overusing OBS, leading to a much lower denial rate. So you may end up looking quite good as relates to your inpatient denials by being under the state average. But if you start digging, and this is great at X marks the spot, let's take a look at what we're doing with UR here and make sure that we're not shying away from revenue that we're entitled to. I think it's a conversation well worth having.
Brought up before is that you could have no denials because you've never billed an inpatient. You would have no denials for inpatient, and that 0 denial metric isn't the only. So I think, but looking at your counterpoints and your other counterbalances and where else you would look, but I think there's tremendous variability in the way these things get classified. And if you're way off norm, it's probably either good or bad. I think that's where, Sean, you're saying the opportunity is get in and look.
I think that's a great point. Yeah.
Sean, thank you. Michelle, we're going to jump in.
Oh, I'm sorry. Go ahead, Brian.
No, we're going to introduce Marting Law. So I'd like to introduce Rochelle Marting. Thank you, Sean. Rochelle, tell us a tiny bit about your organization and what your plans are to do about denial management in 2025.
Yeah, sure. Well, thank you again for having me on the panel. I'm excited to be here and some familiar faces and some new ones to talk with today. My name is Rochelle Marting. I'm an attorney with Marting Law. I'm also a registered health information administrator and a certified coder. Spent the majority of my practice helping providers, both facility and professional side, on issues that surround coding and reimbursement. That has historically involved helping with defense during a third-party payer audit, whether that's commercial or government payers. That has transitioned over time to helping with appeals and even into kind of fractional support with managed care contracting, where I really emphasize the terms and the conditions in contracts, making sure plans are following state law and federal law, and putting mechanisms to teeth to those provisions into the terms and conditions of managed care contracting. One of the things that I evolved into doing that I think is just so important is listening to the revenue cycle teams and the clinical teams, and in discussions like this, to escalate bigger picture trends that we're not going to solve on a claim by claim, denial, or even facility by facility basis, and to work with associations like the American Hospital Association, American College of Physician Advisors, state hospital associations, HIM associations, on advocacy efforts to give examples, give vignettes to help advocate for policy change on a broader level.
Well, you just walked into my question, because I was going to ask you, is there contract language that you recommend goes into these managed care contracts that can help the denials management team or the audit management team? And can you give some examples of that?
Yeah, absolutely. And when I think of language that can help with denials, I think of it sort of chronologically in the life of a claim, starting at the point prior to service even beginning. Maybe this is at the point of prior authorization. So language in contracts might refer to Medicare Advantage prior authorization rules, the time frame for response, the process for appeals, any details that you need if prior authorization would be denied. What are the credentials of the professional on the plan side who will make those decisions? Kind of setting the stage for when and if there is an adverse determination, you can point back to whether those processes were followed. And it sets the stage for potential escalation on a broader level, not necessarily claim by claim, but where you can take lots of examples to a health plan and say, you're not following these terms at a systematic level. So starting at that point in the process, all the way to when you're talking about timely filing, exceptions to timely filing. Exceptions might be, we didn't know that the member had your health plan. We tried, we exercised due diligence and couldn't get that information through reasonable efforts, and maybe having an exception there. A really common exception that I build into contract language due to some unfortunate experiences of professionals and facilities is an exception to timely filing when we could not get the claim to the plan, not at any fault of the provider, but because the plan system had incorrect data. If you have the wrong date of birth for Rochelle in the health plan system, it gets rejected at a clearinghouse. It never even gets into the door of the payer's processing system at no fault of the provider. The claim was clean. So we build into some contract language and exceptions to help avoid timely filing denials in that sense. And then prompt payment language. The time frame in which a payer issues payment and interest if they don't pay timely, but the way that that can relate to denials is that if you have a denial that is eventually overturned with appeals, what that means is your claim was clean from the beginning and you've been waiting for payment for months or sometimes years, and building in language to say that looks back to the date you should have paid us under timely filing prompt payment rules and were owed interest throughout the process. So those are types of examples all the way through the appeals process. Payer has a certain amount of time to respond to an appeal, and building that into your contract. And something that I really advocate for is putting teeth to that language. What happens if they don't meet their obligation? The what if needs to be in the contract. If we don't meet our appeal time frame, plan not meeting their appeal time frame, we revoke or we rescind that denial and we issue payment. Whatever that is, insert the consequence, but having that language in the agreement.
Consequences, right?
That's right. That's right.
So I know there's a couple of panelists chomping at the bit who've had that experience. One I personally know, but I'd like to open up it to the panel that if you can look at your experience in contracts and address that with Rochelle, and either ask questions or make suggestions on something that's around what Michelle was talking about in contract language supporting the denial management team.
Yeah, I have a question. Rochelle, what's your experience with contracting directly with independent review entities, either for claim by claim loser pays versus, a 3-party agreement where you can use it as your entity? I found on the authorization side, the idea of having an external reviewer, what's built into the Medicare Advantage process, if you can successfully get it there, has been a great level set for payers when they're not the sound source of truth, the only source of truth. And have you had experience, or do you recommend, language in contracts encouraging external review or an internal review where you can use that to avoid the larger contract escalations of having to have a bulk amount of cases, issue specific?
Yeah, it's a great question. And it's a challenging one when you're talking about the major national plans, because the response is going to be, as a national plan, this is our process, it is what it is, right? And we can't create provider-specific pathways and procedures. But what I have done and tried to really enforce in those agreements, because so many of the large national plans don't do all of their audits and their denial management internally. They often have contractors, whether it is on a prepay or a post-pay basis, that are looking at claims and helping the payer or the administrator make those decisions, is put language in the agreement that any contractor they choose to use must follow the same terms. They must have access to the contract, follow all of the same procedures, and you, health plan that we are contracting with, are ultimately responsible for making sure that happens. The challenge that I run into if we were to contract with that third-party entity directly is that they are often also contracted with payers, and it creates almost inconsistencies because they've got language in their agreement with the payer. We've got language in our agreement with the payer, and then we have language directly with this third-party entity, and deciding in any particular circumstance which of those provisions govern becomes challenging. But those are all things that are work outable in an agreement, I think, and it's a great idea to kind of level set and have an independent entity. It's something you could also work into your contract directly with the health plan to say at the second level of review, or for medical necessity reviews, these will go to an outside independent entity that we will mutually contract with. Not that you're paying for plan, not that we're exclusively paying for, but maybe we split the fees for that. And then both sides have a stake to ensure before we appeal, we better be sure we're right. And before they deny, they better be sure they're right, because we will both have some expense and skin in the game if we go to that level.
I had a quick comment and maybe question too. So in terms of timeliness and prompt payiness, from a data perspective, that is a very great use case. We can kind of tell when those remits came in, and if there's some consternation about what a clean claim is, you probably agree about that. So that's just, by the way, if you were looking at timeliness and those prompt pay penalties and interest penalties, like data can feed you a lot of things that are really, really good there. And the other question was like, just, is there a state, aren't there state laws about prompt pay? Some of these states have prompt pays, but you should at least do that and then interest and penalties,
Nearly
right?
every state that I'm aware of,
Yeah.
Sean, yes. But so that's a really interesting contracting nuance too. State laws often apply to the types of plans that are governed by state law. So fully insured plans, marketplace exchange plans, they may not necessarily apply to employer self-funded plans, which is a large portion of what we deal with. They might be superseded by federal Medicare Advantage rules. Medicaid programs may have different prompt pay and interest penalties. So it's you have to be very conscientious in the contracting language, how you are referring to the state prompt pay and interest laws. If you just say as applicable, that means they will apply when applicable under state law. But if your contract says something like, we health plan will pay timely and we will pay the amount within 30 days, and that's what your state law says, and we will pay the interest if we don't pay on time using this formula. What you're doing with that language is saying, we're going to use this law, but I'm not referring to only when it's applicable. I am just saying, period. That is the time frame, and that is the formula for interest. And it's really, you have to really massage that carefully in your contract language.
Yeah. Good point.
But I love the concept that you've pointed out, that you can see that in the data. Because I don't think a lot of providers leverage the State Department of Insurance for prompt payment complaints enough. In the state of Missouri, we have really good interest and penalty language. And I had one claim, I think the allowed amount, I'm just throwing a number out there, was something like $50,000. But because it had been several years before the payment finally came in, with the interest and penalty laws in that particular state where there is a daily penalty, the amount came to almost $250,000 just in interest and penalties when pursuing that with the state. So it is absolutely worth a look if you see that that's a trend.
Yeah. I have one question. I'm dying to see what your thoughts are, Rochelle. We get a lot of back-end audits from third-party auditors where the master agreement, the contract, may be silent as to audit timeframes. an arbitrary statement will be put forth in audit request saying that you have 30 days, you have so many days to respond to this. Absent a request, then there will be a take back. How do you deal with that where that's not anticipated or specifically contracted under the master agreement, and it's a third party agent acting on the insurer's behalf, posing an arbitrary timeline on a process?
I think you've raised kind of three different concepts, all in the same request process. So respond to our decision within a certain amount of time. And I think you gave 30 days. I think that's pretty typical. But if you go back to your contract, or the contract may be silent, but remember it often incorporates policies and procedures. So policies and procedures or provider manual may say providers have 45 days to respond, right? So it's incorporated by reference into your contract. That's one point where I see a big gap between contracts directly with the provider and what their third-party review entities are enforcing. Let's say for whatever reason, we got those records out or we got an appeal out on day 31 and it's rejected because we didn't respond timely. I would do exactly what you're doing, Dr. Smith. I would go to our contract, which references policies, which says we have 45 days, and push back in that sense. That's one piece. The second piece you mentioned is a look back period. On what I understand you mean by that is how far back, how old of dates of service can we even look at when we're going back and auditing? And I'm going to say it depends. It depends because, like you said, Sean, most state laws have some sort of look back period. I'm on the Kansas-Missouri border. Missouri has 12 months, Kansas has 18 months, but those are limited to the types of plans governed by the Department of Insurance. So if you have language in your contract that says 12 months, because that's what our state law says, well, that's applying to everything, unless a specific product addendum says otherwise. So it really depends on the way you've got your contract worded, what type of plan you're dealing with, and what the relevant state or federal law says. And then the third issue I heard you raise in almost the same sentence, Dr. Smith, is taking the money back before you appeal. And there may be state laws governing that as well. Often contracts address this, we, the plan, we have the right to offset or to recoup amounts that we deem overpaid. And you've kind of raised two great contracting opportunities. What is an overpayment? And the level of support or justification a plan needs to allege an overpayment. But also that while they have the right to recoup or offset, you can negotiate within a contract an exception. And the exception is if we timely dispute your finding, you will not recoup or offset until we've exhausted our internal appeal rights. In other words, we keep the money until you have finally adjudicated through exhaustion of internal rights that decision. And what that also does is encourage the plan to respond to your appeals timely if they don't get a chance to take the money back until the end of the process.
Rochelle, thank you. I'm going to take a moment and introduce Dr. Brian Moore. Dr. Moore is the Chief Medical Officer and Lead Physician Advisor for the Atrium Advocate or Advocate Atrium Health System. Dr. Moore, thanks for joining. As you know, we've been integrally involved with the Physician Advisor Association for many years, and your experience with peer-to-peer really is unmatched. So tell us, how would you take all of this data, this information? Do you share it with your new physician advisors? Do you train them how to use the data? Tell us a little bit more about how you make data actionable in your organization.
Yeah, and I'll tell you, realize that a lot of what we're talking about is claims level data, which is what, when people talk about denials, they need to understand how you can get to a claim denial or no care given, so a missed opportunity with delays for patient care that's needed. Much of this comes through some sort of authorization process, and where the physician advisors work in most physician advisor programs, it's in evaluating the true medical necessity of a patient, if it should be inpatient or obs, especially in the hospital environment. You can get into other places like post-acute care. And it's getting the auth secured. And as we know, Medicare Advantage in particular has had a really significant higher denial rate than expected. And there wasn't parity in the coverage for the Two-Midnight Rule that came out in 2014, and that there has been a parity, a difference. So you have a much more likely chance of cases attempted to be pushed to a long observation stay inappropriately, in our opinion. I've seen heart attacks that have stayed in the hospital for 4 days that end up losing all opportunity to become an inpatient because the plan denies it up front. And then that honestly will be terminal or directive of a claim denial if you do it. And often plans or hospitals will accept that denial. So the peer-to-peer strategy, which most people know about, which does occur on authorizations, it's not regulated, it's informal. It looks like just another way that you got an auth. And so you need to track data on this, and I'll explain why. Because if you are able to actually successfully implement peer-to-peer strategy or other auth strategies that you can force through the regs, you'll end up correcting that. And that won't show up in your metrics. That'll just show up, hopefully, as a clean claim. And so your rev cycle might not even know all that denial avoidance activity that you're doing. And then to take it to another level, we found this happening in post-acute settings, and this has showed up now in the OIG. It's been part of rulemaking, but between inpatient, post-acute settings, other issues, infusions, this can be used as a delay denial, which ultimately results in no care or payment degradation, that you won't get paid even though you gave the care. And they use the auth as a determinant factor, and it can come in different denial codes, but ultimately it's very hard to appeal and overturn. And so we just wanted to show, I wanted to show, not a slide, but a quick run through. This is not how to do it. This is what's possible. And so using data that we did in our ability to overturn these on the front end, we were able to get support because we found an opportunity for Medicare Advantage in parity in access to, a disparity in access to post-acute care. We put together a multi-discipline team. We would stamp the medical necessity of rehab. We felt like we could no longer tolerate 6, 7, 8 days in the hospital trying to get an auth for post-acute care for strokes. It was bad care. And so we implemented what we call no delay auth. We're thinking about it really should be called cared first auth. Traditional Medicare, there's no pre-authorization. People transition essentially with an internal stamp of medical necessity, and then they go over, they get their care pretty seamlessly. Medicare Advantage, unfortunately, the pre-authorization has made a lot of news, and it really takes a long time. There's very high initial denial rates. They're hard to overcome when patients are waiting in care. They routinely deny and delay access to post-acute care. And frankly, people just give up. Doctors give up. People think that the plans, you can't, it's not that they believe it's okay. They just don't think that they can overcome the plan at that auth level. And so they end up just not transitioning. So next step, so how do you do this? What we did essentially, next step, we put together, we told the story to we used our data to tell the story about our successes in the inpatient space. We explained because we had credibility. We took all of our peer-to-peer overturns, and RevCycle understood the financial impact that had because they are clean claims. All right, so you get paid relatively quickly as a clean claim, and you secure significant amounts of payment. We were successful with that. So we said we could pivot. So we wanted to essentially reproduce the Medicare process and preserve our appeal rights on the auth side, right? There's an auth denial, a claim denial. There is no claim until after the care has been given and it's been submitted to the plan. So we screen for CMS criteria, we submit the auth, and then we transition as if they were Medicare, and we fought it like it was Medicare Advantage. And then we measured, we were able to then take, instead of a guessed time of delays, we measured how long did it take us to get the actual auth secured. And we had all the resources ready for the plan tactics to say that you're not allowed to do this. How dare you transition somebody who's had an acute stroke 5 days before that auth is done, okay? And so next step, but our system was front to back. We had put together a team of lawyers, we had RevCycle involved, we had our contracting folks involved just so we could handle any of the calls we were doing something wrong, egregious. And we were ready to, at the initial auth, we were going to submit the best initial auth. We were going to force them to give us a timely determination. We were ready to appeal all of them because we had already pre-screened them from a MedNeck standpoint, and we knew Maximus was not going to be very helpful in this, but we knew it would go through that. And then we were ready to take these all to ALJs, and then depending on what happened to ALJs, to the MAC. We had full commitment, full financial commitment to this. And what happened? Next step. Next slide. So we basically, in the initial year and a half of this, we transitioned 525 MA patients, and we had very strict data collecting and reporting to tell the story. We had a final approval rate of 94%, which is now up to 98% because sometimes those ALJs take 6 to 8 months. And we got people into rehab, and we fought the auth while they were in rehab, which, by the way, when you win it and it overturns it, it's determinant of that claim payment. Next slide. So this is part of the data collection. I always say it starts on a napkin, goes to a piece of paper, goes to a spreadsheet, and then goes to some kind of database. That data, you have to go down that continuum whenever you're starting something. This is our final data set. It does tell us things. This is one part of it, one dashboard to show you, but it lets people know we have a 94% approval rate. We have an initial auth denial rate, depending on the plan, of 70% to 50%. So that means less than half routinely are approved on your initial auth. The initial auth, you have a delay of 2 to 3 days. If they overturn on the initial appeal, you have about 4 to 6 days, and then nobody's going after that, unfortunately, if you don't get it overturned. So we saved almost 5 days a patient, and we'll see some more data. And that's hospital days that we've saved. That's an expense. So when you're trying to get resources, you got to tell data. Most of these things, if we organize work around it, it will not only be good patient care, it will not only be a full level set with the plan, but what it will be is it will be cost effective for us as well, because and it's better for patients because they're not sitting in a hospital taking up resources they don't need to. This is one way to tell the story, and then you got to think about how to tell it better. Is 400 and whatever the days, we're 2,565 days, is that as impactful as, hey, we saved 7 years? So how you tell your story, it's data storytelling, it's that concept. My team, we got educated on it because I felt like we have to continually educate our executives to get them engaged that we can do this. We are on the right only on, and we can get resources and keep resources. Next slide. All right. We didn't expect this, but this work, and I always say, everything you do around the contract, all these claim appeals that you're doing if you're contracted, the auth appeals that we're doing, peer-to-peers that you're doing that are not regulated, that all is hit into CMS. We didn't realize this, but when we were doing this, this is all in front of CMS. It's the regulatory pathway. These are regulatory patient protections to have to get access to care, timely access to care. And so as we were filing our briefings on why the plan should process it, why they couldn't dismiss it, they brought lawyers instead of doctors to these ALJs, and their main goal was not to discuss medical necessity, was to dismiss it, to say that this is really a payment dispute. Unexpectedly last year, July 19th, I think it was, there was a lot of work done to say that no matter when an auth request comes in, the plans cannot dismiss them. They need to say if it's covered or not. And that's where often in your process, especially concurrent hospitalizations that weren't planned, they'll just ignore them. And so this says they're not allowed to. Now, does that mean the regs, like covering the 2 midnight rule, are going to? No. And so they still continue to do this. We actually went to a level 4 MAC on this because judges were buying into the argument they could dismiss it, that it wasn't pertinent. And we had 2 ALJs that are not precedential, but they are directional for other ALJs. And we think that this is going to be part of what's informing the 42.8, the new rulemaking. But this is the plan should still give you a medical necessity determination that the member can still appeal. And we use the member appeal rights on this. And so we can change the system, and the rules are evolving. And this is a viable thing for us to do to prevent the claim denial. Next line. So I just want people to know it takes a lot of work, and I equate it. It's more intense at startup work in the beginning. It's putting patients over the paperwork of getting an auth. An auth is to make sure people don't get medically necessary care and we don't overutilize. I absolutely feel we can engage payers on this. We can be partners with them so that we don't have overutilization. It does occur and we need to attack it, but we cannot let the fear of that really reduce our ability to represent patients and get them timely access to medically necessary care that they should have gotten. They've been waiting for their whole life. And we did not put revenue at risk with this because we executed it. It's a lasting process, and most and foremost, change is possible, but you really have to have a front to back approach. You have to attack all aspects of this. And if you look at how many claim denials are related to the authorization failure or defect, because that process is so darn complicated, it is not easy to appeal. That's the hardest thing to be able to do. But once you come up with one common strategy, you can execute it. Last couple slides here. You know, and this is just saying where we're at. What happens when you put care first is where we should be, where this health system should be. Next slide. We change the system. And this advocacy that Rochelle is talking about, you can do this work and you can fight and grapple with payers all you want. But this data that Sean is talking about, you know, the approaches I've done with Brian and Kendall's, you know, help on our appeals, we don't need to just win the cases we need to win. We need to provide transparency into what's actually happening. The biggest aha I can say that I provide with data, once you get your wins and you start doing this differently, executives start to get deeper into your work you're doing, and it's in little bits. You got to be able to tell them, but when they see what it is, nobody can believe it. Most families, and I think what we're seeing with the recent kind of focus on this, most families have dealt with this personally and can't understand how to navigate it. Well, I'm an expert physician. Rochelle's an expert lawyer in this. So everybody here are experts. This thing is so darn complicated. And so being able to show how wasteful this is, the resources that are in the system to navigate it are not directed at patient care. And that we need to change that.
Dr. Moore, I couldn't help but hear you say that at least for IRF, you are also standing in the shoes of the patient, the member. And so can you talk a little bit about that? Because I often don't understand why most organizations aren't taking 2 bites at the apple. I've got my provider appeal, but I also represent the members' rights to access care. Are you seeing a shift or a change?
Yeah, you know, it is a little bit complicated. It requires some operational chops. You know, the PMS form, especially the 1696 for an AOR, you know, you can't do it as an organization. You have to do it as an individual. You have to process. You have to keep them informed. There's a lot of things that you have to do. But we are aligned with patients on this. This isn't about just getting paid. This is about access. If the auth fails, the ultimate thing they're saying is that it's not medically necessary. And we obviously, so when they talk about plan directed care, if you're contracted and stuff, like we're a delegate of the plan, but if we have misalignment on what's medically necessary, we're more aligned with the patient in that than the plan. And so helping to get access to the patient's ability, there's patient protections in there to be able to ensure access. You should be using this to make sure you're aligned with patients on it and you fulfill your responsibilities. But it's a viable path because it's the easiest way to review and or to an ALJ. And if you don't appeal something that's denied, it looks like it was correct. It looks like they were right and you were wrong. And that's often the hardest thing to do. And so using appeal rights for patients and doing that as long as you truly are aligned and you're working on their behalf, I think it's one of the underutilized strategies in healthcare to be able to stop payer activity.
Dr. Moore, your example of the changes that happened last July in a nationally published CMS manual, I think it is such a good example of the product of advocacy, because I know you and Dr. Hu had worked extensively with CMS on those exact same topics, and then to see that clarification come to fruition to help what you're doing in patient care and avoid denials, I think is so important. And I got so excited the first time you did this presentation, and excited to share that at least one hospital I work with, we are doing this as well. It's new, so I hope the next time we come back together, we'll have stats that hopefully are as strong as yours on how we're doing in that program. But what I really liked about the way it was designed, in considering something like an instant authorization or a quick authorization, ultimately you're still striving for the authorization. And I think that is so important, because whether we're talking Medicare Advantage, state law, Sean, most states and Medicare Advantage have rules that say when you get prior authorization, that is an approval of coverage and payment and cannot later be withdrawn, rescinded, or denied based on medical necessity. You know, maybe other issues on the claim, but not from a coverage perspective. And so I love that you're pursuing the process to get the authorization that gives you some pretty good assurance that on the back end, that claim should get paid. And the other thing I really like, that I would be interested at some point to see how your data reflects this, is by getting the patients to the right level of care and not accepting the denial and moving them to SNF or home with home health or home with nothing. By getting that right level of care, in theory, I would imagine you're avoiding some readmissions because of that close monitoring you're getting in rehab, and you don't get paid for those readmissions often from many types of plans as well. So that's another financial loss that you're completely avoiding in this process.
Yeah, agreed. And it really is the concept of, you know, comprehensive approach to it. But I'll just tell you, we have delegated all of this essentially outside of our advocacy for patients. This falls on the receiving SNF. This falls on the plan. We navigate all of these different plan portals and all these different plan, and we wonder why it's become such a burden. There's not standards around it. And I'll tell you, my biggest argument would be, why shouldn't we own this process? It is it's gone such awry in our society and in our healthcare system that if we own this and we can overturn it, you know, the non-covered issue or failure to fully secure covered issue is very hard to overcome on the claim side. Even if you have a med nec out on it in your contract, it's often fully ignored, and they use it to say that, sorry, we're not going to review this because it failed authorization. So we have to change this dynamic, because if it's not covered, fine. And there are cases sometimes that we'll get in and we'll have a different picture in rehab, and we won't appeal them. Like, have integrity on our side. Like, we won't appeal them. But for the most part, this issue is just, it's got so much power on the front end if you aren't able to navigate it to completion.
So I've got
So we're going to pause for just 1 minute, and we did create a poll for the users or the attendees. So if you have questions for Sean or Dr. Moore or Rochelle, we're going to come back right after this poll. This should take about 3 minutes max. And then Ryan O'Hara is going to follow up, and then we're going to finish up with Dr. Smith. So Eric, you want to give about 30 seconds, depending on the number of slides, 30 to 45 seconds to let the folks use this.
Can I ask Dr. Moore a question while we're waiting?
Of course, of course.
It might be a dumb question. I'm trying to get a handle on pre-authorization denials, and it is a mess. So why isn't there, or is there, and I'm missing it, a place on the claim to put your pre-auth number or notation, and this payer has to accept it? Like, why doesn't that exist, or does it exist and I can't find it?
Yeah, we generally track it, and I thought we included it on the claim. It's usually somewhere in there with a number.
There is a spot on the claim. Yeah, it's
often, but often what happens is like a keystroke. So we've seen what happens is, and this is kind of my mantra, that if a plan makes a mistake, they don't pay. If we make a mistake, they don't pay. But they'll often not keystroke in the auth as being complete, and then you have to appeal it on the claim side. And so I think the issue is that, though, the bigger part is that it's not the ones that you have in auth that are your biggest risk of denial. It's somewhere it failed it. And then there's this mentality that will be reviewed again later when you have a claim denial. And I'll tell you, that is just generally false. And so I think now that that's being explored, is the best place to have that in the contract, you know, because it's really hidden behind the contract. And so, I personally feel like a lot of what we can do is we might be holding claims when we have auth denials, and we might just continue working that auth denial until completion, because then we don't get the claim down.
All right,
Ryan,
well, thank you very much for taking the time to do the polls. We're now going to introduce Ryan O'Hara. Ryan is the managing principal of the Denial Research Group. And in all transparency, it is a payer watch organization, but Ryan's clear focus is on disrupting and changing things, and the way that revenue cycle leadership looks at managing denials. Ryan, thanks a lot for attending, and it's interesting, an interesting first question. But you mentioned before that you don't think cash goals are the right metric that rev cycle should be looking at. It's outdated. Why do you feel that way?
Yeah, after all the expertise brought forth by Rochelle and Brian and Sean, here's where I'm going to start probably making outlandish statements, but this is what Kendall and I do, so prepare for the next half hour. One thing I do want to follow up on Dr. Moore for a second, because he said something and framed up something that it took me a good 8 years in my career to start framing up in a different way. And, you had talked about the 7 years of, days of hospital stays that obviously consume resources and are costly and keep a bed or a service from being administered to another patient that needs that. And I used to make claims like that a lot as well. And then it took a smart coder, which we've got one of those on here, and a smart doctor, which we've got 2 of these on here to help me reframe that argument. And I think the argument is that anything that's good financially is probably good clinically too, right? Quality and financial outcomes are very, very parallel. And so I think that would just be one thing I would tell the group is, as we're making these arguments, it all feeds back to quality of care, delivering of care. And what I would say is those 7 years kept people out of hospitals and into the appropriate setting. And, again, the smart doctor taught me that the longer you stay in the hospital, the worse it is for you, the patient. After a certain point, right, there's a curve to, we've got you, but if you stay in that hospital 2 days longer than you should, and we don't discharge you appropriately to the right place to receive that ongoing care, shame on us, because we're exposing you to other risks that are associated with acute care stays. But it's just something I learned a long time ago that I reframed, and it's helped me in my relationship and working with doctors as well. So,
and Ryan, if I could just add, you don't mind adding, just the concept of whatever is good clinically generally is going to be, good financially, because it gets out waste in the system. So whether or not it's good for each party financially, but we need to get rid of the waste. This is all waste we're talking about, and that waste has financial complications. And the biggest thing I've overcome in our system is it's not worth it. The concept of it's not worth it. And that's somebody usually looking at their individual part of the pie. They're looking at their one area siloed work, it's not worth it. But to think it's not worth it, think differently about this. We all need to, payer, provider, cut out the waste and the obstruction for our patients and for our physicians and clinicians that are navigating this. I mean, that time is valuable. It has a cost. That cost is often not quantified.
Yep. So Brian, back to your question about cash goals. So I have a theory on cash goals, and I think we disclaimed in the beginning they may not be universally accepted. They may just be my opinions. But I do think that cash goals on the surface, they seem like this clear target. This is kind of where cash should end up at the end of this month. And I am certainly not advocating that we don't try to predict cash flow. That's not what I'm advocating. What I'm advocating is the way we use cash as a goal. And I think, Sean and Rochelle have pointed out some flaws in this as well. But I argue that it keeps you really mired in current state. What do I mean by that? Well, cash goals are reactive by design. They focus on kind of maintaining a status quo, that is, what's my net revenue or the result, and you end up chasing, I would argue, yesterday's performance instead of identifying those discrete and individual opportunities that present opportunity for improvement. And again, I would argue that financial improvement is also clinical improvement. And so I think, what I would argue is there's kind of an uncomfortable reality that meeting or exceeding cash goal equals progress. And I would say the way for me to argue this best is to argue that the easiest way to hit your cash goal is to miss your previous cash goal. And I would argue that that alone says that the metric is kind of stupid. And you kind of set up this cycle of failure that is following constantly lowered expectations and a false sense of achievement. So I've had boots on the grounds in probably 200 plus hospitals or health systems over my career. And I see all the time that we go through your cash goal and it's like, well, we're 108% of cash. We're 114% of cash. And that's consistent over 8 months of performance. And that again, to me, would argue that that goal is not reflective of something that equals progress at the end of that. It is you as an organization using some simple metric to make yourself feel good and comfortable about where you're performing. So the other, I think, kind of reason I say cash goals are kind of antiquated in their most current design is the way that they're derived at. They are often framed as a percentage of net revenue. Now, I think of net revenue as cash, or gross charges minus contractual. That is not how hospitals think of net revenue. They think of it as cash minus contractual, minus denials, minus bad debt, minus administrative adjustments, minus charity write-offs, and anything else that ends up in a deduction that says this is what cash is. And it's important to realize that there's a very clear distinction between what true net revenue is and what cash is. And I think that term gets very convoluted and misused. Cash is what we get. Net revenue is what we expect to get. And that could be on 1 episode of care or 1 million episodes of care. So just add a bunch of zeros after a 1 and you can kind of see the order of magnitude here. So cash goals are typically, now there are ways to get more sophisticated in them, and that's not a service I offer, but there is a way to get more sophisticated in them. Cash goals are typically built as, what is my cash? How many days of posting did I have? And let's use that on some sort of rolling metric, typically 60 days. And then it says, how many cash days do I have this month? How many posting days, right? So you can see how the argument or the goal itself is just, how do I maintain current performance? Not how do I actually improve, not how do I carve into that deduction beyond the gross minus contractual, but how do I meet kind of a standard of performance that I have performed at over the last X periods of months. And so what I would argue is that long and short, right, it encourages complacency, not in individual human performance and the work that they're doing and the sweat and the equity that they're perspiring to try to get money in the door. That's not what I'm saying. I believe most people work really, really hard with the tools that they're given, but encourages complacency in, we're 110% a goal, we must be doing great. You're 110%, that tells me the goal is not very good. You should miss a goal every now and then. And you should hit a goal every now and then. And that to me equals a goal that is worth fighting after. And I would argue cash goals don't really provide that. They're more an exercise in reporting than they are kind of a strategy to identify inefficiency. So, finally, what I would kind of just say, and it's a term that I use a lot, is that when you focus on process rather than static outcomes, it sets your organization up for adaptability that, let's face it, this industry demands adaptability. Being up on the provider side of things demands adaptability because the payers are changing the rules. They don't tell us they're changing the rules. And it's a very, very complex interwoven operational process. So that is my outlandish statement of why I would argue cash goals drive complacency, and they're not really a very good operational metric.
So Ryan, you've got that, you mentioned that 200 plus boots on the ground, you have a wealth of experience, but denials have been increasing. What I've noticed is that we've got at least 2 large hospital information systems that purport to be the end all for really managing the patient's experience, managing the medical record, but denials are worse than ever. They really are. So I can't say that it's a big box solution within Epic or a Cerner or a Meditech. What is it hospital revenue cycles should be doing with this increase in denials, Ryan?
Yeah, I mean, I've taken notes, and I think every single one of our really smart panelists has kind of hit on something that is part of that solution as well. So let me use Sean's data, right? Directionally knowing how you perform on a static subset with other peer facilities, I think is directionally important, right? There's something that's, I would argue that kind of data is more valuable than did I hit a cash goal or not. I think Rochelle brought up data and contractual terms and things like that. I would argue that metrics like denial overturn rates and root cause analytics that say what are payers kind of doing uniquely to me, right? Sean might be a compass, Rochelle might be what Rochelle's talking about is more GPS, or it gets me down to specific, tells me where to go. But now I got to start doing some account reviews, and I got to figure out what these payers are doing based on adjustment codes, mnemonics that we use inside of our system to help kind of directionally get me to opportunity. And here's the thing, if you do that, good denials prevention groups have a parking lot full of 60 opportunities. Now they're only working on 3 to 5 at a time. And that parking lot continues to get, more stalls assigned to it as well. The opportunity is perpetual in nature, right? So I would say that it's understanding directionally how I perform, understanding specifically how payers are affecting me, and understanding what are some of those nuanced process improvement opportunities, to Dr. Moore's example that he gave, that allow us to start to move the metric. If we sit here and use data and say, at a macro industry level in 2020, denials were like at 8.3, I think, %ish, 8 point something. And now we know they're at 13 point something. And Sean, I think, has presented even data that it might even be worse than that. That's unsustainable, right? You can't say my denials have increased by 50%, and I can go to 100 revenue cycle leaders in the country, 100 physician advisor leaders in the country and say, have you also increased your staff by 50%? And I would argue most of them are going to say, no, I have not. Well, how do you fight an ongoing problem unless you start moving towards prevention? So the short answer to your question, Brian, is you have to invest in prevention. You have to get upstream, and you have to start saying, where are the opportunities for me to turn the spigot a little bit so that 13% doesn't become 15%, and 15% doesn't become 18%, right? It's how do I maybe just hold at 13, or even better, how can I get 13 to 11? The only way you can do that is investing in infrastructure to get you upstream. You've got to use data to get there. And the last thing I would say is you've got to bolster your argument. We've got an attorney on here, and again, 2 really smart physicians. And if anybody's heard me on any webinar in the past, and in fact, I'm happy to share with this group the same legal snippets that we shared with the group back in December as well. But your argument has to be constructed in a way that makes the clinical argument clear, use evidence-based model, and to the extent you want to, uses legal language and reference to support that argument. Now, will that get every first pass denial overturned? Absolutely not. It'll get more. I would argue that it'll absolutely get more overturned first pass. But to Dr. Moore's point, you've got to be willing to take this to the last thing. And what a really, really sound argument, bolstered by evidence-based models, legal reference and research, and clinical reference and research allows you to do, is get to that final stage. And you, whether that's ALJ or whether it's anything else, an independent arbitrator who says, it looks like the hospital, the health system is making an argument that's supported with data and research and reference. You just seem to not want to pay, right? So you got to have the upfront argument be better, not for the sake of just winning more first pass denials, which you will, but it lays the concrete foundation by which you can win it at your final stage of appeal. Frankly, insurance companies, because they make the rules, are too lazy to really go to that extent. They just say, we're not going to pay you because we can. So I mean, that's the thing, is I would say, get data, get upstream, bolster your argument.
Thank you, Ryan. And look, you keep speaking of that second really intelligent physician. We want to make sure we get to him. So I'd like to take a moment, introduce Dr. Kendall Smith, who is the Chief Medical Officer and Chief Physician Advisor for Payer Watch and for Adam. And Dr. Smith, you've just had really, you're at the forefront of creating what we call a clinical legal argument strategy. And you and Ryan together are espousing a marriage between clinical improvement and revenue cycle. So why don't you, if you could, give us an idea of the kind of data that you use to create actionable insights for teams.
Sure. Eric, if you could tee up the first slide. I think that this is a kind of a unique niche that I found myself in my career, and it's actually one that I've come to enjoy, which is the strange world of denials. What I found is that it really gives you a holistic picture as to what's going on in an organization and the ability to drive significant improvement in the organization, to have discussions across silos, be it from managed care contracting to individual physician departments, different to the C-suite as well. So a denial ultimately represents a failure, either a failure of the insurer to recognize its obligations and terms under its contract and pay appropriately, or something that the hospital failed to do. It could represent inadequate physician documentation. It could represent a failed attempt to get a valid authorization for any number of the cases and reasons that the panel has enumerated. As Sean talked initially about the idea of Hive's data set being the compass, the data that we're collecting, working back on back end in denials, tends to be a very, very precise GPS. And we look at root causes and assign a root cause to cases, and those root causes then allow us some very precise metrics and ability to start to drill down into areas of opportunity, discussions with payers, discussions with departments. And so this slide in general, I need to, excuse me, move this just away if I could, starts to take a look at various reasons that the cases were denied and overturn rates. I found in the two slides that we're going to look at that it's the extremes that you want to focus on. Things that are in the green. So if, for example, you've got a 90% overturn rate for, let's say, authorization not obtained payer issue, there's something going on with that contract, or there's something going on with your authorization that you're able to bring back out. Was it not, was the authorization number, I think it was Sean's question, not submitted on the CMS 1500? Was that omitted and you were able to supply it later? There's a process issue there that starts to leap out, even though this is a green metric. The red metrics just as well start to speak to individual performance opportunities. So inpatient procedure not performed as an outpatient, incorrectly denied. Those are case statusing issues. And for an organization, this may be an overly concise or too many ways to slice this data. For us, this has become a very telling metric to have conversations across the rev cycle, across the clinical cycle, and start to sit down and look and say, okay, we've got issues with contracts, we've got issues with physician awareness of provider policies that need to be incorporated now into specific documentation to comply with provider policies. And it's amazing what you start to see when you, one, look at and start to compare yourself externally vis-a-vis Sean's compass, but internally to your own GPS, and you're able to slice this data into specific buckets and start to dig in those buckets, what will turn out in terms of opportunities for process improvement. And if we could move to the next slide, Eric, this is the one that I really fixate on. It's a simple thing, and I know, Rochelle, you talked last year at NPAC about the idea of a appealability score or a predictive score as to the likelihood of success of a claim. And this is done in organization based on the opinion of the clinician that's handling the claim after all facts are considered. So reading the payer's letter, the payer's denial, the documentation in the chart, looking through the registration materials, and then rendering an opinion as to how likelihood, what the likelihood of success of that claim is going to be. The red and the green again here are huge opportunities. The green is inevitably when I see organizations with cases that are rated as good or greatest opportunity to overturn, writing these cases off. We're not pursuing these to the end of the earth, as far as you're contractually allowed to go, and perhaps even further if you wanted to bundle these up and take them to state or federal court, depending on the plan as related. If the payers haven't, and you can focus, you can slice this by payer and start to look at some individual payer behavior, but this is lost money. If you, Ryan, from a rev cycle perspective, are walking away from the good and greatest cases, when you start to open these things back up after they've gone through the payer appeal process and they've still been upheld, quite often we've been able to start to dig in those and have some peer-to-peer discussions, Brian. I worked with Brian with a particularly high dollar case where we actually called the employer directly because their TPA was making an egregious decision, and the payer stepped in. But it's a question of having the ability to slice that data and take a look at it. From a operations improvement standpoint, the very little and small opportunities for overturn are fatal flaws in a hospital process. Something happened with physician documentation, something happened along the path of getting registration that failed and doomed this claim. Perhaps it was someone forgot to put a 2 midnight attestation on the chart, admitted the patient as an inpatient, and it was a short stay without a Medicare inpatient attestation of an expectation greater than 2 midnights there. So as we start to look at these, and behind these appealability scores, we're able to drill down into individual cases, is what makes this phenomenally useful for process improvement. We've got the GPS, I think, sitting here, to which, Sean, you're talking about comparing yourself externally. We've now got the ability to start to look at some of those differences and say, as an organization, where and how do we improve? Where are we having issues with contracts, Rochelle, with our specific payers? Because we'll start to see, as we slice and dice this data by payer, vast differences in payer responsiveness, payer outcomes. You have the same physicians documenting, Brian, chart to chart to chart using the same EMR. Taking, once you admit enough patients to the hospital, you can argue they're probably statistically insignificantly different in their demographics, Medicare Advantage plan to Medicare Advantage plan. So why the vast differences in the number of denials from a plan and the denials of overturns? And these are the conversations that I think go back to the C-suite through your physician advisors with data in hand to start to have that discussion. Rochelle, when you mentioned getting around to contracting terms and specific contract language. So to me, these two slides, as simple as they are, when you look at the data behind them, the cases behind them, and you start to sort into them, this is the sum total of what Rochelle, Brian, Sean, and Ryan have talked about. And this is it operationalized at the individual hospital level. So
one of the things you said, Dr. Schmidt, you quickly mentioned data in hand. And so I also caught that from Dr. Moore as well.
Yes, both physicians can tell you the wisdom of not confronting someone without data in hand. Anecdotal Anecdotal anything will get you shown the door by a physician so
Well,
quickly.
especially if what we've learned, at least what I've certainly observed over the last year or so, is that the C-suite, especially with all the recent publicity, now seems to be paying attention, really. And so where we plan to disrupt at Payer Watch this year is encouraging employers to get involved in overseeing America's health insurance plans, who are actually helping insure their workers. And the fact is that employers, hospitals, and patients all make up the community. The payer is not part of that community, but we are. So everybody on the call here, I think we have an opportunity to take a grassroots approach. And as Kendall and Dr. Moore have indicated, we have to move these, we have to bubble this up to those leaders, but they're going to require data. They want to see actual information and actionable insights, and then go do it. So with that, we only have a few moments left. I want to quickly say, we'll send the poll answers out if the poll actually works. And then also, last webinar, we asked you to answer some survey questions at the end. I want to indicate to you that Noel Jimenez from Theta Care answered all the questions, and we picked his name out of a hat of 200 respondents, and he has asked us to donate that Xbox and TV to the Children's Hospital of Wisconsin. So thank you, Noel, for listening. Way to go, Noel Jimenez. And so if you answer those questions at the end, once again, we'll pull names from the hat. But in the meantime, Eric, do we have a question that we can pose to the panelists? Anybody that is able to stay on afterwards, panelists, great. If you have to go, we understand. But Eric, why don't we see if we can get some questions from the audience?
Sure. Start with this one right here. Regarding contract language, what do you recommend when certain large national payers refuse to put in language favorable to the provider?
Going out of network.
I
Is
can't hear you,
everybody-
Michelle.
I'm assuming Rochelle is
This is Rochelle.
I think she's on mute.
Looks
Rochelle,
like she's
can you
not.
hear us? Did you hear the
All right.
question, Rochelle?
I can answer from a non-legal standpoint. I would just say that you got to escalate it because you're going to get the contract language you get. I mean, the contract language is not just something you can force down the throat of a payer. It's a negotiation, and I doubt you'll ever get ideal language. I would just recommend that if you think there's opportunity, escalate it, because leveraging contract language and kind of calling the contract can be an end stage, but there's a lot of ways you can settle disputes on the meantime if you have good data just to show that a payer is not doing what they're supposed to do. But making sure you at least have an internal dialogue, because your contract language will not be ideal and it will vary by payer. And so I have a feeling that there's still opportunities to get things overturned even without necessarily having a violation of the contract, because often that's in the eye of the beholder.
Rochelle, are you still on? Okay. We can't hear you, unfortunately.
I'm not sure what happened. I'm trying to looking into it now.
Okay.
There is another question here. A little backstory to it. I recently received an audit denying primary care physician office visits, no procedures performed, due to no general consent to treatment. I've never received a denial like this before. Can private payers deny for this reason? They noted 42 CFR as a denial reference, but did not note specific regulation in 42 CFR. Any advice?
Well, Rochelle can't give her advice because we can't hear her. Dr. Smith or Dr. Moore or Ryan, I'd like either of the three of you to chime in.
Be honest, I'm stumped. It's not something I've heard of. This is something that's new to me.
Well, we'll reach out to that question.
Specific language, 42
We'll
CFR.
never ask the question, and so
Yeah.
we'll research it and get back a cogent answer to whoever asked. Time for one more, Eric.
Let me see if I can find one. With the no delay authorization process, were you fighting with contracted or non-contracted MA plans?
Contracted. So we were contracted. They bring up that we were obligated to get an auth prior to giving a service, and they were trying to make that argument that somehow we were doing the egregious thing of, you know, getting stroke patients care when they needed it. And for me, it's such a absurd argument, because we were getting it when they needed it and also demonstrating medical necessity. They were just getting the medical necessity determination wrong. And so from our standpoint, the fact we could do it on that when it requires prior authorization opens up the door, and it should we be delaying care for other things where they routinely, all the high dollar infusions, all the high dollar oncology, all the high dollar inpatients. Should we really be refusing care, or should we just manage the coverage determination for what it is, securing it, and then being able to get that rather than fight it on the claim side and wonder? Because what happens when you lose the claim side, which you will, because they'll say you didn't get enough, then people wait. And that's the argument they can't run away from. They're forcing delays because they employ non-rehab doctors and people, we don't even know who they are, to be able to deny care and then eventually overturn it. And we've taken, it's been like 20% or 15% to the ALJ. I can tell you there was 2 out of, I think, 54 cases that we have done in the ALJ currently, 2 that had rehab doctors show up. So it's emergency physicians, family physicians. They testify that they've never made this decision clinically. So just know that system. I think I'm more than willing to stand up and be able to say we're not violating a contract. Our mission, you know, your processes not get in the way of our patient care. We're trying to be compliant with it. And at the end of the day, I don't think Medicare intends for this process to cause people to wait for their cancer care, wait for their rehab care.
Have you started to notice any change in individual payer behavior as a result of this project, Brian? Like less resistance with some of the payers, or more legality?
I would have thought when you show somebody that I've gotten all your stroke patients care 5 days earlier, and we agree 99 point whatever % of the time, that they would have been like, fantastic, maybe we can delegate this to you. That hasn't happened yet. And I'll just say, if this, and that's the other thing, like predicting how each payer handles this differently. They all have different overturn rates and approval rates. I think when they realize they lose, we are seeing this year, you know, instead of an initial denial rate of 65%, we're seeing an initial denial rate of maybe like 53%. So we are seeing incremental change, but nothing that makes me think. The biggest change we're seeing is a change in CMS's evaluation of it. So I will just tell you, you know, filing, you know, there's a new complaint system you can file if Medicare's Advantage plans are not doing what they're supposed to, and then doing this in a public forum where, you know, it impacts star ratings, it impacts their, you know, if they have overturns from IREs, it impacts it. Forcing that to happen, it only happens when they have a denial, period. So if they're denying incorrectly, they should be afraid of if there's external review of it. And so just, I think, yeah, we see, I think it's only a matter of time till CMS hopefully level set.
The complaint process, Michelle, correct me if I'm wrong, doesn't that have an overweight as to star rating impacts?
Yeah, we got my mute issue fixed, and I'd love a chance to go back to those questions afterwards and send those back out to those that sent the questions. I apologize for that. You're exactly right, Dr. Smith. So the complaint process that had historically been available to members only, now providers can submit a complaint to CMS, and that complaint is a component of star ratings, and there's a line item that says complaints against the plan. So it can have a real impact. And if you Google MA plans and star ratings, the first 5 things you're going to see are MA plans suing CMS for the multi-million-dollar impact that a tiny adjustment in a star rating has to them. So this is a big deal for plans, and it's also a good mechanism for providers to get involved and illustrate and demonstrate the magnitude of circumstances when we think MA plans are not following the rules that they should be.
Yes, yes.
You want to go back to that earlier question, Rochelle, about the 42 CFR and the consent to treat? I'm curious.
Yeah, I would love to. And while we go back to that question,
Yeah.
Eric, there was a graphic I sent to you showing trends in appeal volumes, if we could pull it up on the screen, because I think it speaks to a couple of things you're saying, Dr. Smith, and what Dr. Moore said in terms of dealing with this at a systemic level. But what it illustrated for one organization, sorry, yeah, there you go. This is what it looked like for us as we were fighting back. So we did see a change in behavior. And when we around 2022, all through 2023, really started pushing back and advocating on one particular issue, you see a dramatic drop in 2024. And when we're talking about approximately $7,000 or $8,000 delta for every single one of those cases, the difference between 350 and 492 at one facility is dramatic, and that's cost savings. We don't have to appeal those anymore. Those are not denials that are even coming through the door. And so I think there is something to be said for addressing that at a systemic level, an organization level, rather than kind of a claim by claim appeal. But yes, let's go to the 42 CFR question.
Eric, can you repeat that?
Yep. Let me just scroll back down to it. Okay. Received audit denying primary care physician offices, no procedures performed due to no general consent to treatment. I've never received this before. Can private payers deny for this reason? They noted 42 CFR as a denial reason or reference, but no specific regulation in there.
Okay, so there's a couple of things I'm thinking about there. One might start with the contract, and if there's a requirement in their contract that you have to have a general consent documented in writing, that may be one piece to look at. If it's not in the contract, is it part of that plan's provider manual? Because in general, I think the question said it was primary care. You don't have to get written consent necessarily for treatment. Best practice, sure, say you've got it in writing, but there's a concept of implied consent if the patient's in the room and they're competent to make a decision and you perform a procedure that they have consented to that. But the reference to 42 CFR makes me think that it is either a Medicare Advantage reference to consent, or I know the person said primary care, but if we're talking about it being performed in a facility setting or hospital-based outpatient department of a hospital, it might be referencing a hospital condition of participation to get consent, but it is an unusual one. So there is also a requirement under the Medicare program, if we're talking about a government plan, that they provide sufficient rationale for you to be able to respond. And so that sounds maybe like a deficiency in the denial rationale. If you can't figure out why they are denying coverage and payment, there is some language in Medicare rules and regulations that you could reference. If it's commercial, I think I heard private plan, there are also likely state laws that govern the sufficiency of detail that you need in a rationale that you may be able to reference as well.
Well, I'm going to stop it with that. I want to thank Rochelle. Dr. Moore, who left, unfortunately, he hard stopped. Sean, thank you so much. And Hive Health and Collective Health for assisting today. Ryan, did our research group, thank you. And Dr. Smith, as always, thank you for your time and attendance. We will make sure this is recorded and on the websites to review or to share with anybody else in the denial and appeal community. Thanks everybody for attending, and don't forget the next denial roundtable will be Wednesday, April 16th. Wednesday, April 16th, so we'll have our second roundtable at that time. Thank you so much, and everybody have a blessed week.